I go to Dr. Karvouni, I don't know if you agree that despite desmoglein and in conjunction, of course, with phenotype, there's another characteristic, not very strong, that we had relapses, clinical and laboratory relapses, despite the immunosuppressive therapy. Probably because immunosuppressive therapy in arrhythmogenic cardiomyopathy targets not the genetic or the anatomical substrate, but just the epiphenomenon, the inflammatory expression, as opposed to myocarditis, where we target the very essence of myocarditis. I mean the immunoinflammatory activation. I don't know if you agree. I think it's time. Yes. So it's time to proceed with Dr. Karvouni, cardiologist from the 3rd Cardiology Clinic at the IGEA Hospital and from the Unit of Inherited and Rare Cardiovascular Diseases at the Onassis Hospital. Dr. Karvouni.
Good evening, everyone, and welcome to Cardiomyopathy 2021. The title of my presentation is Relative Apical HCM in a Young Athlete. Should we let him play? We decided to present this case for 2 reasons. First, to bring this particular form of apical HCM to your attention, and second, to share with you the challenges we face in daily clinical practice when we were trying to refine risk in specific subgroup of patients with hypertrophic cardiomyopathy, such as apical HCM patients, who are not high risk, not low risk, but they are lying in between these 2 edges. This is our patient, 23 years old, professional football player, asymptomatic, no personal history, no medications. He first came to our attention in 2015 due to an abnormal ECG found in pre-participation screening program. This is the ECG at the initial evaluation. You clearly see the typical T-wave inversion in precordial leads and minor repolarization abnormalities in leads 3 and AVF. Imaging did not show left ventricular hypertrophy. Maximal LV wall thickness was 8 mm, but there was suspicion of abnormal LV apical tapering. Holter did not show any ventricular arrhythmias and treadmill test was perfect. CMR did not show myocardial fibrosis. Familiar screening was not informative. There was no evidence of cardiac disease or sudden cardiac death in the family. These are the ECGs in the family. Father's ECG showed some kind of repolarization abnormalities in lateral leads, but his echocardiogram did not show any signs of hypertrophy. So at that time, we felt that no formal diagnosis could be made and the athlete was allowed to compete. Annual follow-up was suggested. This is the ECG in 2020. You can see that T-wave inversion has been extended to the inferior leads. This is the transthoracic echo. Left ventricular global systolic function is normal. There is no dilatation of left ventricle and no left ventricular hypertrophy at the basal segment. This is the short axis view. There was no hypertrophy at the mitral valve level. However, in 4 chambers view, you can clearly see the hypertrophy in the apex and the obliteration of LV cavity during systole. This is more prominent in 2 chambers view and in 3 chambers view. If we go to the short axis view at the apex level, the hypertrophy is clear and there is complete obliteration of the LV cavity during systole. The hypertrophy at that level was measured 10 millimeters. Cardiopulmonary exercise testing was normal And Holter for 48 hours did not detect any ventricular or supraventricular arrhythmia. CMR detected relative LV hypertrophy with myocardial fibrosis in the apical segments. Maximal LV wall thickness was 9 millimeters at the apex, while it was 5 to 6 millimeters in the basal and mid segments, respectively. The important finding was the presence of subendocardial LGE in the apex, which is typical in patients with apical HCM. These are the images. You can see that there is hypertrophy in the apex with obliteration of left ventricular cavity, and there is a spade-like configuration of LV cavity during systole. This is present in the apex. However, at the papillary muscle level, left ventricle is normal. Short axis views at different levels, and you see the typical obliteration of LV cavity at the apex. If you compare these images with the previous ones, you clearly see that there is progression of the disease in the apex with hypertrophy and obliteration of cavity. But the important finding was the presence of subendocardial LGE in the apex of LV, which was not present in 2015. This pattern of LGE is called MI pattern and is not typical in other forms of HCM. So what is the diagnosis for our athlete? If we go through apical HCM forms, as they are recently described in a review of AHA, there are three forms: the pure form with isolated apical hypertrophy, the mixed form with both apical and septal hypertrophy, but apex is thickest, and the relative form that applies to our athlete, in which patients do not meet conventional diagnostic criteria for HCM, but share imaging findings with the pure group. The diagnostic criteria for relative apical HCM is D-wave inversion in ECG and loss of the usual apical wall thickness tapering in CMR. Keep in mind that patients with the relative apical form do not reach the apical HCM diagnostic cutoff of wall thickness more than 15 millimeters. So what would you advise? Should we let him play? He is young, he is asymptomatic, he has an abnormal ECG, he has the relative apical HCM form, no ventricular arrhythmias, no family history of sudden cardiac death, but he has the new finding of subendocardial LGE in the LV apex at young age. We know that fibrosis has prognostic significance in the risk of sudden death in HCM. But it's not just the presence of fibrosis, but the extent of fibrosis that was associated with increased risk of composite events. So it is important to have fibrosis more than 15% to consider LGE as of prognostic significance. If we go to the recommendations of ESC for participation in sports in patients with hypertrophic cardiomyopathy, we see that participation is allowed in patients without markers of increased risk. This is a class 2B indication, which means may be considered for individuals if it is desired by the athlete. The markers of increased risk are the cardiac symptoms or history of unexplained syncope, the history of cardiac arrest, ESC score more than 4%, LVO2 gradient more than 30 millimeters of mercury, abnormal blood pressure response, exercise-induced arrhythmias, and extent of LGE more than 15% of LV mass. In our case, no definite marker of increased risk was present in our case. However, we had two markers that have prognostic significance, which is fibrosis and young age. Also keep in mind that application of conventional HCM risk stratification in apical HCM can be challenging because patients with apical HCM have less frequently a positive family history of disease and sudden cardiac death. And we know that sudden cardiac death is heavily weighted in the ESC calculator, which means that very often these patients have low ESC scores. Apical HCM patients have less frequently detectable genetic defects, have more atrial fibrillation, and sudden cardiac death risk factors for them may differ because high-risk features such as apical aneurysm and typical LGE patterns that we see in these patients, apical and subendocardial LGE, are not present in other forms of HCM. And at the end, it's not a benign disease. The annual death rates are similar to other forms of HCM. Unfortunately, we don't have apical HCM specific recommendation for sudden cardiac death risk prediction. In conclusion, our athletes do not definitely meet markers of increased risk, but he is at a relatively increased risk for sudden cardiac death due to fibrosis and young age. We suggested prolonged heart rate monitoring during competitive exercise, and we could let him play if appropriate precautionary measures from his club were there. This was not feasible, so we did not sign him off for competition. This athlete is followed up closely every 6 months with ECG, echo, exercise test, and Holter. Genetic testing has been scheduled. Thank you for attending. The case is open for discussion.
Thank you very much, Dr. Karvouni. Very nicely presented. It's a very interesting case of apical hypertrophic cardiomyopathy, prematurely, very early detected actually electrocardiographically in this pre-participation screening, thanks to your sharp eye, I would say. I don't know if you, okay, Dr. Makrithanasis is with us. So would you like Dr. Makrithanasis to introduce the commentator, Dr. Ntelios?
Yes, of course. Let's see. Okay, so Dr. Ntelios is a cardiologist from the first clinic of cardiology at the AHEPA Hospital at Thessaloniki, and he will provide the comments for this presentation.
Good evening. Congratulations, Dr. Karvouni. It was indeed a very interesting case. I would like to make only a short comment regarding exercise and apical HCM. First of all, apical HCM is much more common in athletes diagnosed with HCM compared to the general HCM population. Now, regarding exercise and HCM, there are to my mind, two major concerns. Does exercise have a toxic effect on the myocardium like the ARVC case? The truth is that currently available data indicate that the answer might be no. The second concern is, can exercise trigger arrhythmic events in the context of adrenergic stimulation during exercise, etc.? Of course, HCM is a major cause of sudden cardiac death in the young. However, exercise-induced sustained VT is rare, and ICD therapies occur in the absence of physical exertion.
Dr. Ntelios, we have a trouble hearing you. If you have, please, can you lower the sound of your speakers? This may improve the sound for the rest of us.
Okay, sorry. This is why current ESC guidelines for sport participation are less conservative than previous ones. Therefore, patients with a low risk profile, asymptomatic patients, no LG, may participate in competitive sports. However, this is a low level, it's a 2B recommendation. So it's important to state that the risk is never zero. This case presented by Dr. Karvouni illustrates very well that follow-up is crucial for those patients. And I think that decision about participation in competitive sports must be made jointly by the doctor and the patients. That's all I want to say. Thanks for the opportunity to participate in this amazing meeting.
Thank you. Thank you very much.
Dr. Karvouni, may I ask you something?
Yes, please.
What was the precautionary measures that you asked from his team?
Okay, the precautionary measures are the resuscitation, the presence of defibrillator in the playground first, and the presence of experienced team for resuscitation. You know that for Greece, it's something that we cannot find it in real life. So
if you think that this patient was in danger for ventricular fibrillation, why didn't it's? I think that we cannot recommend to have a resuscitation team in front of him in order to play ball. This is a little strange.
This is the point that we would like to bring, that we don't feel that this is a low-risk patient, even that he does not meet the definite...
Why?
Because he is young and he has fibrosis at 23 years. I mean, the presence of fibrosis in such a short period...
Small fibrosis.
Yes, it is small fibrosis, but...
to make him an exercise test?
Yes, the
perform an exercise test. Yes, and it was normal.
It was normal, but it doesn't mean anything, I think.
But there is
fibrosis, a patchy fibrosis to the apex, I think.
No, it's not patchy. It's subendocardial. It's not patchy. It's subendocardial fibrosis, but the risk cannot be quantified in such a way. I mean, the cutoff point of 15 is not something that we can take it as for granted. I mean, what if someone has fibrosis 11? Is he fine? Is he fine for you if he has 11 or 12%? And
he has less than 5%. He has a very small LG. And how do you explain that all the apical hypertrophies that we see is in old age? Is 80, 70 years old? I'm not agree that apical hypertrophy is not a benign disease.
No.
He hasn't any aneurysm. He hasn't extended fibrosis. He hasn't very thick walls. I have some doubts about the decision of interruption of the athlete.
There are a lot of data, a lot of discussion in the literature that apical HCM is not considered a benign disease anymore.
There is a question by Dr. Anastasiou. What does a shared decision mean? Actually, I can understand that it is a borderline case, but what worries you probably is the evolution, the progress within the past 5 years, actually. In conjunction with this and with Ari's question, Dr. Karvouni, how often would you perform CMR? Does the extent of fibrosis and aneurysm formation play a role in your decision for ICD implantation? In other words, how would you prefer to follow him in terms of detection of arrhythmic risk? With very frequent Holter monitoring, or with less frequent CMR, or with both? How would you like, regardless of the competitive sports, how would you like to follow him up in terms of his arrhythmic risk?
His arrhythmic risk is followed up with Holter every 6 months, and CMR at an annual base.
Right. So you prefer to have both, actually.
Yes, of course.
And you wouldn't, how can I say, attract some sort of help from genetic tests, because, as you very nicely pointed out, genetic
No.
tests are not very helpful unless we have got double heterozygotes. Yeah.
Genetic information is not in the algorithms for the
Right.
moment.
So what does a shared decision mean? Ari's question. What does a shared decision mean?
Shared decision means that the doctor has to explain to the patient what
Right.
are the benefits and the risk of an action, and what is the evidence for it, and the patient has to give his own opinion on that decision.
Okay, would you like to make Dr. Makrithanasis' final comments, because
A final
we've got
comment
a time
from me.
constriction? Yes,
I would like
Alekos.
to emphasize, never forget the apex from the short axis. It's very crucial in the diagnosis.
Great comment. Thank you.
Yes, and I think that your image from the apex and from the short axis was great. And we have the diagnosis from the short axis, except of MRI. Thank you.
Despite Dr. Karvouni, despite the constriction of time, Aris keeps on firing, actually. Is this shared decision legal?
Legal, what what do we mean
Ari, would you
legal?
like to make a comment? Where are you, Ari? Show yourself. You show your face. Where is Aris?
You are the organizer.
Yes.
You're muted. You're muted. You're muted. Dr.
You are
Anastasiou,
muted.
you're muted.
Can we have Professor Elliot with us, please?
Hello,
Okay.
Barry. Hello.
Barry, we have a problem here. First, if this was a high-risk patient or not, I mean, in relation to the athletic activity. And second, how you do the shared decision process in England. I mean, do you have a law that covers you, or it's something that you perform, as an authority in the field?
Yeah. Before I give you my answer for what it's worth, can I just say that again, I've been sort of reflecting on the meeting today, and where we were 5 years ago, 10 years ago, 20 years ago, and the level of sophistication of the discussion is extremely high. I mean, we don't have all the answers. Maybe we don't have the majority of the answers, but at least we're thinking about what the questions are, which I think is, I think is quite amazing, really. As far as this particular patient's concerned, I mean, I agree that apical HOCM is not a benign entity, but it's equally not necessarily a malignant entity either. And the way I approach apical is exactly the same as I approach any distribution of hypertrophy, whether it be concentric or asymmetric or whatever. So I try to assess the global risk for that patient. So if you have apical and you have non-sustained VT and you've had syncope, I would still regard that as being a very high-risk patient. Now, in this case, I have to say I share the doubts about the scar, because remember that 65% of patients with hypertrophic cardiomyopathy have some scar. So scar by itself, I don't think is a very good measure of arrhythmic risk by itself. And I think we're seeing that in the ongoing HCMR trial. You're aware that there's this international effort to try to determine the prognostic value of scar. And after 5 years, there are insufficient number of events to show any association between scar and sudden cardiac death. So I think it's part of the mix. I agree with the comment that this seems to be an evolving phenotype, so you have to watch this guy really carefully. I agree with that, and I think you have to regularly update your assessment of his risk. But as he stands at the moment, I wouldn't say that this guy is particularly high risk.
Well, I mean, what about the evolution of the disease? The fact that he is young, and do I have? Can you hear me?
Yeah. Hear you. Yeah.
The fact that he's young, and in 2 years' time, he developed a fibrotic apical, in the apex, fibrosis in the apex. Is this worrying you?
It doesn't. I don't think it worries me because I think it's probably we very rarely document the appearance of the phenotype. So this is something I've learned from the pediatric populations, where you're following a child and you see the appearance of the phenotype, and it can be amazingly quick. So you can go from a normal heart to an abnormal heart within 6 months or a year, but we don't normally document that change. Here you've picked up a guy very early because of the ECG abnormalities, and you've shown that lack of apical tapering. And now, unusually, I think, because I think it's quite unusual to see that kind of phenotype evolve, you started to see the hypertrophy appear. But by itself, I wouldn't worry. But I would keep watching, because if this hypertrophy starts to look more severe, extends into the septum, he starts to get some non-sustained VT, then I would assess him on the basis of his most contemporary risk stratification.
You allow him to play in a professional level?
What's the sport?
Football.
Football. Okay.
In Greece.
Yes.
Which club?
We're not saying. Actually, Aris and Dr. Karvouni, correct me if I'm wrong, but following Professor Perry Elliott's approach, and despite our reservations, this player keeps playing football.
Yeah. So then that leads to the second part of the question you asked me, which is shared decision making. Because shared decision making, so there are a number of prerequisites to shared decision making. First of all, you have to be sure that you're genuinely sharing the decision. And I agree completely that you have to explain things, but I think we often think we're explaining, and we're not explaining at all. The patient doesn't understand a word of what we've said. Because we start talking about 1% and 2% and blah, blah, blah. What does that mean to someone, 1%, 2%? So you ask me what's happening in the UK. There's no legal requirement for shared decision making, but there's a science of shared decision making in terms of how you explain concepts, how you explain risk, how you use particular decision tools with the patient, to use graphics to illustrate what 1% really means. If you put a defibrillator in, what's the potential to save life? And trying to show that in a graphical way that the patient and maybe the doctor also understands. So shared decision making, I think, is a process. And then the final element of that, which is, I think, maybe the most controversial thing I'm going to say, is whose responsibility is it to tell someone they can't play sport? Is it the doctor's responsibility to forbid, or is it the individual's right to say, okay, I hear you, but I'm going to make my own decision?
Yes, but this is a matter of each country has a legal context. Okay,
absolutely.
And for example, when I approached the medical association here and said to them, look, when we have an athlete and we talk with him, and then we explain to him that we have a relatively higher risk than the others, and then at the end he dies in the field.
Sure, but I think that's because
you are responsible. You're the only one. You
legally that may be the case, but I think morally, I think we've got it wrong, honestly. Because I think, look at the idiots who drive fast cars, kill themselves and kill other people. And yet it's okay for an idiot to drive a car. But we don't make it legally enforceable to stop people from driving cars or doing high risk behaviors which potentially put them at risk. But in the context of sport, we as physicians, we want to do the best for the patient, but we're taking away that person's autonomy to make a decision for themselves.
All right. I just find, because the time has passed, I would try. No. Yes, I understand partly, because there is a legal context and expression. Yes, and so if you miss something at the end and something goes wrong, then you will be in trouble.
So I understand. Right. But what if he dies in his bed?
Yeah.
What if he dies going to the shops?
You will be in trouble as well.
No, you're not in trouble. You'll be maybe in less trouble. But it was the observation made earlier. You know, if you really think he's at risk, put in a defibrillator. If you don't think he's at sufficiently high risk, then what guarantee have you got for that man that if he avoids playing sport, he's not going to die suddenly? I don't think we have that.
No, we don't have.
The thing, Perry, is that we don't have in Europe a unified way to think about these things, you see? No. And it's very important. I mean, for example, in your country, all right, the doctors are in a very high level of authority and respect, okay? In Greece, it's not exactly the same.
I'm not so sure it's the same here, to be honest with you. But I think that we don't have a formal legal framework for this.
No, I mean the reaction of the society, maybe can be different. And if there is not a legal base to stand on this, then the whole situation becomes tricky. Anyway, this is my approach. I'm not, right?
I tell you what, though, I think everybody's going to die from hypoglycemia unless we finish the meeting. So I think we probably have to call this meeting to an end.
Okay, one final question, because I want to ask something. You and Stamatis and Makrithanasis. What about the people who seems to have myocarditis? They have inflammation, they have edema, they have troponemia, and also they have a mutation, a causative mutation. Do we treat them? Do you use immunosuppressive treatment to them, or it's useless?
Very difficult question. Can I reply with the strength of an example we had very recently? We treated a patient with Brugada phenocopy. This was expressed with chest pain, high troponin levels, and electrocardiogram very characteristic of Brugada syndrome. And after the myocardial biopsy, because of the continuation of high levels of troponin after 1 month, we found no virus, but immunoinflammatory findings in a great extent. So, despite we believe that it's either Brugada that came to clinical expression with myocarditis, or probably it's a Brugada like the so-called Brugada phenocopy. Despite this dilemma, we treated him with immunosuppression. And a day after we started the treatment, we had a sharp drop of troponin levels, and in 15 days' time, we had complete disappearance of edema in CMR. Still, the electrocardiographic findings are slightly better, but still they've got the characteristic of Brugada. Is it a Brugada syndrome, or it is a Brugada phenocopy? You understand what I mean? But we need to treat him. And he reacted nicely. He responded nicely, both clinically and laboratory, with the immunosuppression.
I think it's a great question, because we talk about these kind of cases all the time in our multidisciplinary team meetings, and depending on, you see the same data, and if you're a myocarditis doctor, you say this is classic myocarditis, raised troponin, some arrhythmia, there's edema, we should biopsy and immunosuppress if we see lymphocytic myocarditis, blah, blah, blah. If you're a cardiomyopathy genetic doctor, you say, this is a hot phase of ARVC, and therefore, this patient's at high risk of sudden cardiac death, and should we be putting in a defibrillator? But it's the same data set, but you have a completely different paradigm for treatment. So this is why I think in the way in which we classify and group these diseases, we need to do it in a different way, I think, because the management plans can be totally different depending on what label you put on the patient. And the final point you said, I think it was you who said something really interesting, which I think is also important. In ARVC, we see inflammation, but it comes and goes. And what the driver is to the inflammation during those episodes, I don't think is at all clear, but I don't think it's the same kind of disease as, for example, an autoimmune giant cell arteritis where you have to immunosuppress for 2 to 3 years or even longer. There's something different about this, and it may be that you get periodic exposure of antigen, you get an inflammatory response, and then it settles. But it's a different kind of inflammation. Okay.
Professor Makrithanasis, do you think that the genetic disease is going to be there, and so the inflammation is going to recur, and no matter the treatment?
What I can tell you is that from other experience we have from genetic diseases is that as soon as the genetic test becomes more available, then we start to learn much more about the diseases. And then things that we previously thought that it was unrelated, then we understand that they are related. And the other thing that has happened a lot is that we, as Professor Elliott said, we put a lot of diseases together at a certain point. So there's no really point of over diluting and trying really to make very finite definition of diseases, because in certain cases, as you said, we are seeing two different aspects of the same coin, and this we will learn, at least as far as the genetic diseases are concerned, as long as we are going to do more and more genetic tests, and then we will start learning more and more all the finite aspects of the genetic diseases that are still elusive right now.
Okay, Professor Elliott, please close the session because it's too late today.
So I think it's been a long day, but I think a really great day, and I think we've covered such a huge spectrum of problems, from kids to adults, from ARVC to hypertrophic cardiomyopathy to DCM to genetics to inflammation. As I say, I think the landscape of cardiomyopathy is complex, but the pace of development, the level of knowledge, I think is really impressive. So I'm really looking forward for the next 2 days. So thank you everybody that's participated today, and we look forward for another really good day tomorrow. Thank you.
Good night.
Thank you very much.
Good night, everybody.